Why you got the big eye? See, wait, you do. I see your teeth. You do like I do. I be like, oh, I done got caught. Wait a minute, freeze. You had the big eye, like, uh-oh. I love it. I love it. Good morning. Good morning, everybody. Good morning, everybody. Let's see. Hi, Renee. Let's see if we got any other folks out here in the world. I don't see anybody in yet. Oh, it's just at 9 o'clock. Oh, I'm a little early, huh? We get this train started early. Oh, so how was your week? I know I already asked, but we didn't ask on camera.
It was pretty good. We're gonna talk about my work week when we get into the topic.
Uh-oh. Look, I felt something when I text you and you text me back. I felt something in your spirit. I said, well, yeah, this is about. I got 3 tea bags in here because I knew this was gonna be piping hot strong. I started to bring a whole little warmer right here to make sure that the smoke was coming up out the tea, because I felt that in my spirit. I felt it in my spirit. Good morning. Somebody is joined. Good morning, and welcome. Okay, so let's get this party started. Good morning and welcome to the Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, advocacy, the weather, all of the things we discuss right here on our channel. I'm Clarice Warner. I'm the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC. And since you always say where you're located, I'll say located in Cincinnati, Ohio. And do you know what it takes to be a certified marketable, I can't stress that enough, medical coder? Well, before I introduce my co-host, let me share with you information on a free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Okay, you know I get caught up with the music. I'm sorry. You just see how caught up I get when I'm selected. I'm like, wait a minute, and then I hear another. I said, oh wait, that's a beat right there. Let me just cut this part. I like this, right? It's a whole process. Okay. If you are in Clubhouse, good morning, Shay. Good morning. If you are in Clubhouse, feel free to click the link. If you are interested, or somebody you know is interested in getting more information about the 5 steps to become a certified marketable medical coder. Remember, it's just an email course that is free. There's no charge or anything for the information. If you are on YouTube, Facebook, or LinkedIn, check the video description for the link. I promise you it's in there. I promise you. You just got to scroll down. So joining me today is my co-host, Mr. Jesse, the registered trademark. I need to add this to it. Put some respect on my name, the coding nurse. So, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a very long time. I switched to HIM medical coding in 2014 during the pandemic. In 2020, I created my company, the Coding Nurse LLC, where I help nurses and other people in healthcare with clinical backgrounds transition into the wonderful world of HIM.
Cool. And how's that going for you?
It's going pretty well.
Good.
I am in the middle of, we're almost wrapping up PCS with my class, and we're going to go into actual CDI stuff in about about a week.
All right, all right. I see we got
Fundamentals and all that.
All right. I see we got another little background back there. I'm peeping it.
And I'm back upstairs because for a while I had been downstairs. I'm back upstairs with my lighting.
I see. Look at you doing all the things. The light is lighting and you glowing. Look at all the things. I said, well, okay.
I just changed it. It's totally.
Oh, all smooth and I know you, sir. I love coconut oil. Between my shea butter, mango butter, and coconut oil is all the things over here in this household. All right. Oh, wait a minute. I'm so glad. Look, I've been drinking the tea. I need to slow down before I run out. Okay. I love it. I love it. So if you are on Clubhouse, let me just remind you that we want you to be part of the conversation. So join in. Just all you have to do is raise your hand. We will add you to the stage and you can be a part of the conversation. This is a dialogue here. While we bring the noise, we expect you all to be drumming in the background as well. So feel free to be part of the conversation. And your opinion matters here. It really, really does. And we want to hear from you. We want to hear what is on your mind and what are you seeing in the street. If you've ever been to some of the more structured meetings in health information, this part is called the environmental scan. That's what this is, where we talk about what you're seeing and what you're hearing. So yeah, we're connected. We just do it in our own little special way. All right. If you are on Facebook, YouTube, and LinkedIn, you all know what to do. Y'all been doing this for weeks now, months now, years now. Use the chat. However, if you have a question, just put a Q in front of it so that we know that it's an actual question and we don't miss it. But we do still engage you and put all your comments and stuff on the screen. Sometimes we get mass kicks out of stuff that is being said. So she is something else. We might have to get her on here. Just bring her on. Come on, girl, and show your face and let's dialogue, because you always have something crafty to say. I'll leave it at that. Okay. So church announcements. Where's my banner? Okay. I don't know. It was kind of a dry week over here in my medical coding world. I saw a lot of OIG. They coming. I saw a lot of reports on things that have been reviewed and the actual audit reports and the monies flowing back to their rightful owner, if you will. So I saw a lot of those types of things going. I guess the biggest church announcement is that we will not be here next week. It's my birthday weekend. Wheels will be up. I will be out. So I will not be here next weekend. So save all the commentary, because if I see some stuff, y'all know I pull a whole little note on the side and start adding stuff like, oh yeah, these are all the things we need to talk about. So we can save it for in 2 weeks. So when we come back. All right. Mr. Jesse, did you have any church announcements? Sorry.
No.
Okay.
And I have a little bit. I have some tea that I can spill at the end. It's all going to tie in.
Oh, the tea. Oh, see, I'm gonna have to look. I'm gonna have to make you the solo and run and get some more tea, because I swear I'm gonna run out. I feel it all in my spirit. I am going to run out. Let's see. She's laughing. Let's see. Good morning. Craft the Coder, she's on. Yes, she said, count on me to drum every week. Yes, ma'am. You be drumming. The drums be drumming. Good morning to the healthcare business consultant. Welcome.
Molly and Vicky.
Yes, good morning, Vicky. Okay, wait. She got a church announcement. Did you all hear about Cigna and Modifier 25? Spill the tea, girl. Spill the tea. Spill the tea. that could be part of the church announcements. And so if you all have church announcements, feel free to add it, come to the stage or add it in the chat. Oh, thank you, thank you, thank you. She told me, okay, you didn't show. There we go. Happy early birthday. Thank you, thank you. Yeah, Miss Crafty Coder spilled the tea. Okay, so we'll come back if you, and I'll look for it if you post it in there, and we'll come back and we'll talk about it. So today, if you are just joining us, today we are going to be diving into the definition of the principal diagnosis and what it means to you. Now, let me just forewarn you that Mr. Jesse is on fire about this principal diagnosis, but you know me. So let me set the stage. Now, you know, with the principal diagnosis, we have tools to help us assign them. Two tools in particular that we all should have and all should use in the health information management space. And if you are a coder, the first tool, of course, is your coding guidelines. We talk about them all the time. We talk about, and I'm gonna share the screen and reference them. So we talk about them all the time. These are the Bible, if you will, of assisting you with making sure that you assign and sequence codes appropriately. The Bible. But you also have, and I brought my book. This here, your code book, your ICD-10 code book is also one of the tools. And why do I say your code book? And I'm sure in the 3Ms of the world and encoders of the world, I don't want to throw anybody out under the bus, but the encoders of the world, I'm sure they have algorithms to help you kind of decipher and sequence. But this right here gives you conventions. And those conventions are what also help you determine what your principal diagnosis should be, as well as your secondary. So let's take a look at what one of our little Bibles says. Okay. Let's share the screen. All right. So this is your a shot of the ICD-10 guidelines that are effective for April 1st, 2023. Because they make the changes to your codes, oftentimes twice a year, April and October, oftentimes you will see some sort of revision, addition. I don't see too many deletions, but there will be some type of revisions associated with the guidelines. So it's really, really important that you also peep those guidelines when the codes actually change, because usually there's something going on. And it may or may not be related to the code changes. So if they're adding codes and it's something that is applicable to something they have in the guidelines, they'll add the additional guidance around that. But sometimes it's totally unrelated. And so it's your job, certified marketable medical coder, to make sure that you understand and you peep these guidelines. So let's talk about the section 2. Section 2 is where you get all the goods on the selection of the principal diagnosis. Now, the principal diagnosis is defined in the Uniform Hospital Discharge Data Set as, quote, the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. It also says these definitions are used by hospitals to report inpatient data elements in a standardized manner, blah, 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 blah. Since that time, the application of the definitions have been expanded to include all non-outpatient settings, acute care, short-term, long-term care, and psychiatric hospitals, home health agencies, rehab facilities, nursing home, etc. These definitions, the UHDDS definitions, also apply to hospice services, all levels of care. Okay, now In determining principal diagnosis coding conventions in the ICD-10-CM, remember I just talked about that? The tabular list and alphabetic index take precedence over the official coding guidelines. You hear that part? Did you read that, y'all? Y'all might want, if y'all got this in print, you might want to highlight that, or take your computer and highlight the PDF. Takes precedence. Okay. You can also see section 1A, conventions for ICD-10-CM, where they break down the various conventions and what is what and how you do some of the things. Now, in this piece, and I won't belabor the point because we gonna dive right in. I want to make sure we have enough time to get to the tea of the day. There are at least 9 subsections here that gives you clear guidance and direction on how to select your principal diagnosis. Also, in section 3 of these guidelines, let me get to the get. This is the rules for other or additional diagnosis. So they give you additional guidance on how to determine other. The UHDDS defines other diagnoses as all conditions that coexist at the time of admission that develop subsequently or that affect the treatment received and or the length of stay. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. These definitions, again, apply to inpatients in acute care, short-term, long-term care, psychiatric hospital. They are used by acute care, short-term hospitals to report inpatient, blah, 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 blah. Okay. And then they also added the same language that they did above about making sure that it applies to all non-outpatient settings and hospice services. And then last, but certainly not least, you have section 4. And this is diagnostic coding and reporting guidelines for outpatient services. And so this talks about how you define the information for your coding diagnoses related to outpatient. Now, it clearly says right in here somewhere, the Uniform Hospital Data Set definition of principal diagnosis does not apply to hospital-based outpatient services and provider-based office visits. So theirs is selection of the first listed condition. You don't even use the same terminology when dealing with an outpatient level service. But I don't think we're going to talk about that today. I think we're going to focus on inpatient. So I just want to show you. Okay. Well, if time prevents, I just want to show you that we have the guidance right here. And remember, your conventions in your coding manual take precedence. Okay, Mr. Jesse, I'll stop sharing and I'll let you take the floor.
So I wanted to mainly talk about this issue because I'm so glad because I had all my guidelines ready because I wanted to bring to light how important it is for coders to always refer to your guidelines. Because what I have noticed and what is because language is important and people set the stage. And I know I and other CDI, and we have our meetings, they have issues with the coders, even though most CDI are not coders themselves. But some of them have, experience, so they have learned, coding guidelines, through the years. And what I'm starting to hear, which I don't like, is they keep talking about how coders don't have critical thinking. And that's very problematic. And it's setting the tone for coders to not have a job.
All right, come on now.
And it is important for coders to know the coding guidelines and to apply them. And inpatient, you have some very complex cases, but there's always a guideline that can cut through the muck and the mire and give you a path to where you need to go. And what happens is, where I work, the coders are only allowed to query the provider directly for like BMI, stuff like that. But if there's anything in terms of a diagnosis, they have to contact the CDI who was handling that case, and then we have to consult with them and then decide if a query is warranted, then we send it. And what I'm finding is I have been getting a lot of pushback lately from coders, and it relates strictly to guidelines. Now, they don't know that I have 9 coded credentials and I'm in a we all communicate through secure chat. So they don't know that I know what I'm talking about. So I have to.
You got all the receipts, sir. All the receipts. All the receipts.
So I got to hit them with the guidelines. And I want to give you an example. I had a patient who had a history of osteoporosis. They came into the hospital because they fell out of the bed and they had a closed fracture of the hip that they decided not to do any medical intervention on. So when somebody has a history of osteoporosis, if you go to section 1C13D2, that guideline clearly pertains to pathological fracture.
What is it again?
Section 1C13D2.
Okay, you can talk. I'll pull it up.
And the coder sent the query, sent a secure chat to me to query for. First, she asked me where did I see osteoporosis, and she said that I needed to query the provider for the relationship between osteoporosis and the fracture. I tell her exactly what notes I found osteoporosis in the past medical history, and I cited this guideline and told her that this guideline provides the linkage. So she escalates it to her manager, thinking that she got a gotcha.
Not a gotcha.
So her, I think it's IC.
Wait a minute, let me go upstairs. Let me go to the top.
So
you said 13.
Because you can see the chat messages under the comment in Epic. So she escalated to her manager, which when you escalate a case, you're supposed to escalate your manager and the CDI manager. So she didn't do that. But her manager responds back and tells her to refer to the coding guideline and CDI provided. So meaning that you're wrong, sis.
Yeah.
So he ends up. This is D2, osteoporosis.
Why keep popping out? Okay.
So, because the guideline is very clear.
Here we go.
So it says right there, the code under M80 identified the site of the fracture. A code from category M80, not a traumatic fracture code, should be used for any patient with known osteoporosis who suffers a fracture, even if the patient had a minor fall or trauma, if the fall or trauma would not normally break a normal healthy bone. Isn't that self-explanatory?
Looks that way to me, sir. Now are there any conventions that?
No.
Okay. All right. Well, go ahead.
So then after she gets this message, she said, I had another case, same situation, osteoporosis, pathological fracture. She sends it to me again. And I'm like, what is going on? So then I have another query. This was just a query request. This was just yesterday. Now, this patient had known primary liver cancer, known secondary metastatic bone cancer, diagnosed now. the person had a biopsy of the rib because they wanted to determine whether it was truly metastatic or a secondary or another malignancy. Why they put an 84-year-old man through that, I don't know, but they did.
Mm.
So the coder sends me this long message talking about I need to query to rule out rib cancer. I'm like, what? And this person was in the hospital for 11 days. I put the primary liver cancer, and I put the C22.0. So I put that as the primary diagnosis. Now, after an 11-day stay, her primary diagnosis was weakness. What insurance company is going to pay for an 11-day stay for weakness? When somebody has a known primary and secondary malignancy, you would be weak too if you had metastatic cancer.
Right. So you would think, and I agree with you, Crafty Cody, 100%. You would think that before you go to the next level, that you would do your homework, that you would make sure all your ducks in a row, that you would have the information to support, your thought process before reaching out. That's why we getting popped with they're not thinking, they're not using critical thinking skills, because I think it's reactionary. They just, let me just, no, do your research and do your work first. Oh my God.
Right. So then, this is my last example. I want to get to my point. Then, the same pathological coder comes to me with, there was a patient who was admitted to the hospital. They had cancer as well, but they were admitted with weakness. They had acute kidney injury. Everybody has an acute kidney injury, especially of a certain age, because they don't drink enough water and they're creatinine. Mm-hmm. So that's an easy one that they always want to get them. And acute kidney injury if it's true acute kidney injury, it will resolve with inpatient with either IV hydration and or a change of medication, sometimes both. But there should be an improvement. So this person did improve, and I picked dehydration as the primary diagnosis, and the cancer and their other secondary conditions after. So the coder sends me a query. This is another guideline. This is 1C2C3. It's the management of dehydration due to the malignancy in the guideline. So she sends me a query and a query request for me to contact the provider to see if the dehydration is related to their cancer. So I respond back. I said, a query is not warranted because with what you're requesting, there will not be a change in the sequencing nor the PDX. She responds back to me, why wouldn't the sequencing and PDX change? Because if it's related to dehydration, then the cancer should be listed first. We're going to read guideline 1C2C3. You have it pulled up?
I'm looking. Wait a minute.
Okay.
You got 1C.
1C2.
2.
Neoplasm.
Right.
Section C, coding and sequencing of complications, and then 3.
I got it. I didn't want to scroll. I've probably been giving somebody problems with all the scrolling. So I was like, let me get it there before I pull it up. Okay. Okay.
So it says, when the admission/encounter is for management of dehydration due to the malignancy, and only the dehydration dehydration is being treated intravenous rehydration. The dehydration is sequenced first, followed by the code or codes for the malignancy. This stuff is cut and dry.
Very. Very. And it's clear they're not, and I don't understand. Again, that's some training and some education, but you should already have that coming into the door as a coder, knowing that you need to make sure that you're following the guidance that's provided to you. But before you even escalate, y'all making us look bad.
But one of the coders has been working at this particular hospital for 3 years.
Oh, Lord. She said logical thinking and critical thinking is out in the pasture with some of these folks. Oh, wow.
But this all goes to, and then, what happens is it's on the back end is time consuming, because when they contact you, it takes time to look up the guidelines. It takes time because like you're working on 500 cases, and because when they contact you, the person's already been discharged. You done forgot about that case and then move on. Then you have to go back to your notes and look through and look at what you coded, and then you got to try to explain to them why you coded what you coded. So that's a lot of time.
Yeah, when it should be done on the front end. So again, if you take the time to reference your materials, your Bible, the information that you have, not only in your coding book through the conventions, but also the coding guidelines, oftentimes those questions could be answered. But when you should escalate it is when it's ambiguous and you're not 100% certain, but you've already done the research to support one way or the other. You just are trying to get someone else's eyes on what your thoughts are. Which is why they would escalate to your CDI people. But if you're trying to give the CDI people your job, because essentially that's your job. Your job is to make sure that you code it appropriately. Oh my God.
What they should be doing, how it should be working in the perfect world is the coder should be contacting CDI since they're not coding. And they should be giving them the guidelines. No, because of this guideline, you can't do that.
Exactly. That's what I'm saying. They should be doing the work. Yes. And your job is to actually query the provider to find, is there a reason to add this, that, delete, whatever, to on the provider side, not necessarily have education and training to the coders, because that seems like what y'all doing. Y'all got a whole level of a job. I guess it's in the fine print of all other duties as assigned, but now you have to provide education and training on coders to making sure that they use the tools that they have been given. Wow. Oh, wow.
All strictly guidelines. It's not hard. It takes 2 seconds to look up something. So this example, this same coder, because I cover one hospital and it's like maybe 4 or 5 coders, so they all rotate through the same case. So she already coded the case, and the person was admitted with acute on chronic heart failure. Okay, fine. They had an exacerbation, so they were admitted. But the caveat to this was their admission date was like March 21st.
Mm-hmm.
On March 6th, they were admitted to the hospital with an N-STEMI.
Mm-hmm.
Now, the coding guidelines said that you code you code a heart attack, anything from I-21, that category, you code it as active for 4 weeks. She coded it as old. When you code it...
Wait a minute. I'm sorry. You triggered my reflexes.
When you code it as current, it becomes an MCC and it jacks up the DRG, which is what it's supposed to do, because there's a lot that goes on when people are recovering. People have subsequent heart attacks and everything within a month. So my supervisor was on vacation. Well, she started vacation, and she's going to be gone for like 10 days. So I asked her, I said, "Well, who's going to be covering for you?" Because this was in our CDI. So she went through the whole spiel. So I told her, I'm asking because when I contact this coder and tell her she's wrong, it's going to be a problem, and I'm really tired of doing coding education. I said, so I just want to be, so when she doesn't respond, I want to know who I need to, or if she responds, I want to know who can I escalate it to because I don't want to be bothered. So apparently, my coworker, the CDI, didn't know that was a guideline. And apparently, they had been mucking up that process. So this was, I kid you not, our meeting was at noon Eastern time. At 3:45 p.m. that same day, my preceptor, who is an MD, very nice man by the way, but it just goes to show that they didn't believe me either, and they needed to convince themselves. He sends me this long drawn out coding guideline that basically says the same thing, and then he says at the bottom, "You're right, Jesse." I know that. If I wasn't right.
Oh my God. That's that microaggression. See, that's microaggression all day. Some of the things that you got to deal with when folks don't want to believe what you know that you know. I've known you for a while now, and you know me for a while now, and we both know that when we come in locked and loaded with it all, with receipts, with all of the things, evidence, backing everything it is that we say, and not just in our opinion. Now we'll add our opinion behind stuff, and we joke and we play, but trust and believe. We've done the research. We know what we're talking about. Oh my God. And to your point, and you shouldn't have to show all of the alphabet behind your name. You shouldn't have to. I said what I said, and that's what I said, and I meant what I meant. Period. Oh yeah, I got a whole bunch of stuff for her. We coming back to her, but go ahead.
Because the other caveat, the other addition to that too, because I get where you're going, but the other caveat is I'm an LPN. See, they're RNs and MDs. So how could
you? Because you've been out here in these streets, and you've been in this game long enough, and you have the experience to know. Oh,
that's why.
Oh, that hurt. Oh, reading is fundamental, isn't it not? Reading is fundamental. What we say, it could all be so simple if you just read.
Yeah. So, I really wanted to, because as coders, it is your duty, your obligation to know, even if you don't know any guideline by memory, know where to look things up. Look things up before you escalate an issue. That's all.
That's it.
Because they love to minimize the role of a coder anyway.
And y'all giving them the ammunition. Oh my God. By not doing your job. That's your job. We always talk about other folks not doing their job. We talk about the physicians now. We ain't going to be on the physicians today. But now we got to talk about making sure we do our job. Do your job. Oh my God. Oh my God.
I really just wanted to, like, we have to raise the bar, and we have to maintain a standard, because I'm telling you, like, I hear it all the time. They always want to say, well, coders don't have critical thinking. You know, and that bothers me, because it's an insult. Because they're trying to insult your intellect. And no. So that's what I really, really wanted to talk about today. And it's the same because at the end of the day, it all comes down to money. And this can be applied to the outpatient setting, because everything, ties into, which we've talked about on, on here on Clubhouse numerous times, medical necessity.
Yep.
You have to justify.
That's right.
Why this person is here, why this person is under your care. Because 11 days for weakness, no man. If you are on an outpatient and somebody's chief complaint is back pain, and that first listed diagnosis is breast cancer. I mean, unless you're trying to, and then even if you're trying to rule out metastatic, you still can't have breast cancer as the first listed. So because you have to address why the person came in. It has to make sense on the back end when you ask these people for their money.
And to me, you're absolutely correct. If you're following the guidance, it makes it automatically flows. It automatically gives you, okay, this is the stuff that I need to be looking for and making sure and verifying before I actually add it to the code. This is why this all makes sense. So as coders, you have, to your point, you have an obligation to make sure that you're understanding what is happening during this hospital stay, what happened at admission, what happened, what's going on, and then support that using the tools, your guidelines, your conventions, using all of the things to determine to support, because you are, while the physician or the provider in their documentation is telling the story, you numerically with these codes, or alphanumerically with these codes, are also telling the story, but you're telling the story as to the medically necessary reasons why they had to do XY procedure, the medical necessary reasons why they had to stay this amount of time, why these additional resources had to be expended for this particular patient. So again, it's you are part of that. We always talk about that. You are a link in that chain of the revenue cycle, but you got to make sure you're doing your part and assisting in making sure that what you have gleaned and abstracted from the documentation is supported by the codes based on guidance and guidelines, based on the documentation. So you got to do your job, and you can't expect somebody else to clean it up afterwards. Your job is to do it on the front end. Yeah, and there again, we all understand, everybody, because I don't have guidelines memorized at all, but trust and believe, I go to them. The first thing I do, I go to them. Let me make sure everything is good here. Okay, everything, nothing's sitting here, no conventions. Okay, boom, let's go. And yes, it's some extra steps. Unless you're in a specialty where you're doing the same thing and seeing the same thing over and over and over again, it may be a step that you won't need as often. But if you're in a space where you're seeing all kinds of things, different things that could potentially come at you on a different basis, and we all know there are certain areas that can be tricky, you definitely need to make sure that you're going through your guidelines and your conventions when you're coding in those areas. We all know that. We've been trained to know that. So don't be afraid not to use the tools that are given to you. And then back to the whole critical thinking skills. Critically thinking is using the information that you have provided to help you support what your stance is, to help you support your codes. It's a no-brainer here. It's a no-brainer here. I don't understand. Why are they making this? It can all be so simple. They rather make it hard. They rather make it hard. I saw women before. I see you right there on the tip. There's an article, and I'll pin this article down in the link, that talks about choosing a principal diagnosis, and she gives a couple of tips on what it is that she does. Her name is Audrey Howard, and she is a senior inpatient consultant, compliance and audit services. And she wrote, or I guess maybe it's a blog. It's a blog, I guess, for 3M in their Inside Angle. And so what she does is she asks herself these questions. So she said, the first thing I do when I review a record of a patient admitted with multiple diagnoses, which could potentially meet the principal diagnosis definition, is separate out the conditions and evaluate each one individually. I understand a lot of the coders are on a time constraint because the push is to get the information out, But you want to make sure it's quality there. Now, it ain't about the quantity, it's about the quality. So get the information out, but make sure you're doing the right thing and that it's accurate when you push it out, because then they do quality. Most operations do a quality check, and they will be checking to see whether or not, well, they should be checking, let me say that, should be checking whether or not your quality standards are there. So you got the productivity piece, and it's all great and well if you're pushing out the appropriate numbers, but are they correct? It's the quality there. So you got to keep that in mind as well. So it says, did this condition so these are the three questions that she asked herself. Does this condition necessitate inpatient admission? Would the patient have been admitted to the inpatient setting for this condition? That's question one, even though it's a couple questions in one. Two, did this condition meet inpatient criteria? Was the patient sick enough? Was the treatment significant enough? And then three, could this condition stand alone as the reason for admission? And then she puts together this table. Here, let me show this. She puts together this table. I'm doing a lot of screen sharing today, right now. She puts together this table that says, like, the condition, the signs and symptoms, lab and diagnostic tests, and then any treatment based on scenario. And she gives this scenario where she, itemizes this thing, and based on the information, based on what she knows to be true for the selection of the principal diagnosis, based on our coding guidelines, based on any conventions that we have, she determines what the principal diagnosis is. So I'll put this link in there for you guys on the YouTube video, so you can go back and pull that. Okay, Mr. Jesse, you were going to say something. I'm sorry.
So I just wanted to really just, because there are times when, there is some discussion that is needed between CDI and coding, because and I'm not by any means trying to say that I know everything, because I don't, but I know where to look when I have a discrepancy or when I'm not sure. And like, I had a case, and I understood what they were trying to do, but when you try to explain your position, and then when you use logic and you still don't agree, then it's time to go to the next level. So I had another situation with the coder where in the ED the person was admitted with colitis and acute kidney injury. Once again, so because certain conditions are supposed to resolve if they're truly those conditions. Like, another one that gets me is somebody has dementia, but we want to diagnose them with metabolic encephalopathy. See, metabolic encephalopathy is supposed to resolve as well, just like an acute kidney injury. You're not supposed to still be discharged with either one. So this person with the colitis, they had IV antibiotics and they had IV hydration. They came in with a really high creatinine level. It was like almost 3, which is really, really high. So during the course, the level did come down with IV hydration, but it did not it was still twice the normal. So I coded the colitis as the primary diagnosis, and as the acute kidney injury as a secondary. So the coder and the coding manager both agreed that acute kidney injury should have been the primary diagnosis. But when the person had a renal ultrasound, it was determined that they had a mass on the kidney that needed to be evaluated further in the outpatient. So that is no longer a kidney injury. That's a condition.
Mm-hmm.
So if the condition has not been diagnosed, then you can't use acute kidney injury as the principle, because then the acute kidney injury, or as you think it is a symptom of another issue. The colitis was treated with IV antibiotics and IV hydration. So I told them, I explained all of that, how the the creatinine is still not back to normal, so there's still an issue. So it's not an acute kidney injury. It's another condition which is already documented on the ultrasound. And I said the principal diagnosis also goes to what condition got the most resource. And I told him about the IV antibiotics and IV fluid trump renal ultrasound and IV fluids, because that could have been a 2-day stay if you could just do that. The person was in there longer than that for the IV antibiotics for the colitis, and they were discharged on PO antibiotics. So it's very cut and dry, but they fought me tooth and nail. That case still is not reconciled because they refused to change the principal diagnosis. So the hospital it's just what goes on in the back end in this inpatient CDI is, when I tell you, crazy. And it's really nothing but ego. All you got to do is follow the rules.
That's right.
I don't have no ego, but it's not my money at the end of the day. But I don't want nobody coming back to me saying, Jesse, you didn't do this right.
That's right. That's right. She said, Crafty Coder said they need to make sure they hire coders and test them during the hiring phase. That way the employer understands the coders' competencies. Yeah, I agree. Let's see. I love to put the respect on it. It says research is part of a coder's job. I ain't trying to be in the front of the OIG explaining why I didn't read the guidelines. Because they can come for you, coder, as well. It's not just the provider. Ultimately, the provider is the one who submitted the bill and signed off and said that everything was true and accurate to their knowledge, but they can always be like, but I hired this person. They were the one that was supposed to know.
Research is a part of any job in HIM, any capacity. Because I have to Google is my friend. Just yesterday, I had a case where the person was admitted for, I forget the reason, but they had a ultrasound or a contrast, ended up having an anaphylactic reaction and an end-stemming reaction to the contrast. And I had to look, it was definitive. I had to look it up. I'm like, okay, so then I had to go to, and there is in the table of drugs and chemicals, contrast medium. There's a code. So it's just, research is just part of the job, and just research and be open to feedback, especially when somebody is citing a guideline.
Right. And you can't be so in your feelings that you can't get that constructive criticism based on you asked them, they came to you and you asked the question, but you don't like the answer, so you're gonna shop it until you get what you want to get. No, especially when you got the information right there in front of you in black and white, which you should have taken the time to look and research prior to even wasting. Look how many resources have been wasted because this particular coder didn't do her job off the top.
And then, so this is the key I wanted to show, that it all comes together, because just like AI is trying to come for coders, AI has come for CDI.
Oh, really?
One of my co-workers is on this committee with 3F. So they talk about, because we have a lot of issues with 3F current. So they were talking about these issues and the capabilities of 3M. Well, apparently 3M has they have some kind of system, another platform that can create queries and send them directly to the physician.
Wow.
Now, from what the CDI reported back, from what they saw, the queries were not compliant. So she was like, oh, so it's okay for a machine to send the non-compliant query, but we're not allowed to send So I was like, I said to myself, I said to her, I said, well, it's time for a human and actors to weigh in on these kinds of issues.
It's time. It's overdue. It's overdue.
They're trying, because if they have this technology, it's going to be implemented somewhere, somehow. This is the T. Now, Actis is nonprofit, because they're .org. Guess who is a major donor to Actis? 3M.
Wow.
So, what that means? That means it's a done deal, because they're not going to say a word.
No, because that's where they bring up. That's no. We ain't gonna cut the hand that feeds us. Not at all. Wow. That's interesting. Again, it's always about where the money resides. Follow the money, and you can follow what is happening. Wow, that is interesting. We don't stand a chance, do we? We don't stand a chance. And I think with those queries, all they really would have to do is train and teach and write the code for those queries to be compliant. So I think the person who may have initially put those, they probably wasn't in our space understand that. So really it takes someone who is in the space to provide the information to write those, to give the machine the specifics on what it is that is a compliant query, and then ask the specific questions on what the provider needs to do. So that's just a little tweak that they need to do there. But to your point, I think it's overdue. I think these questions, but I don't think those questions gonna come, because if they're in bed together, I'm trying to stay warm. I'm trying to keep my snuggle bunny right here. I ain't no, and no.
But see, this goes to show why the industry is the way it is, because when the organizations who are supposed to advocate for you and your profession don't advocate for you and your profession, you're pretty much just flapping the breeze.
Right. And so don't advocate for raising my rate or taking my money if you're not going to advocate for the job that I do, the skill set that I bring, and or protecting us from what's to come, and or because it's already here. So it's not even what's to come. It's already here. But then what's the next level? What are the steps that we need to take to align ourselves with this new technology? What is it that we need to now bring to the table? What additional skills or skills that need to be tweaked so that we are part of the new narrative, if you will, with these AI tools, because they're already here. They're not going anywhere. They're working every day. Like I worked using the chat GPT. They done created a whole other little thing that is stronger, faster, and all of the things. So they have people working diligently to make it be the best that it could possibly be. But look how quick it turns around. Look how quick it turns a coder around to first think about, oh yeah, I think I need to make some changes. Oh, let me go get the information and education to make those changes. Oh, that takes forever when they can make changes in a snap. So yeah, we gotta be proactive, not reactive.
Now, Crafty Coder has a really good comment. This is so down.
So here is what it comes down to. Do the facilities get less denials and recoup from a live CDI, or do they save money by taking a live CDI out and just deal with denials if they come? That's a great question. And that would be a business decision. And that would be based on the bottom line, because yeah, And they would factor all of that. So you also got to factor what's the cost of those denials versus the cost of having the system that does the AI versus the cost associated with that employee. And they would weigh all those factors to determine what it is. Against AI, I will just research denials, because if the front end is AI, yeah, and it's going to be the crazy part is, I guess, think about, so they're using AI on our side. What happens when they use the AI on the insurance side? What is that going to look like? So that's going to be even a bigger mess that someone will have to deal with, because then you're going to be fighting stuff that could potentially be wrong and off and crazy.
Well, I saw an article. Actually, it was a video about what's going on in California. They use an algorithm for these doctors to make all these denials. And they were saying that one doctor had denied 60,000 cases in a month or something. And they did the calculations, and they said that the average time spent on a review was less than 2 seconds because of this algorithm. And they just use the algorithm to just deny stuff. So now I think they're being sued.
Yeah. You're right. That would be crazy, insane, extra dumb AI edits in the insurance. Yes, it would be a mess. Oh my God. Okay, we are at the top of the hour. Let me come back to our church announcement from the Crafty Coder. She said in May 2023, Cigna will require all in-office procedures billed with E&M and modifier 25 to have documentation before payment. That is going to be huge. Oh, we're going to put a pin in that one. We definitely going to have to come back and talk about that. That's going to be, wow.
It is.
Especially if others follow suit. And I'm sure they may. because this has been a problem for years.
Because everything that they say is separate and distinct ain't separate or distinct.
Oh my goodness. Well, thank you, sir, for bringing this to our attention. And yeah, it to your point, it just gives us a bad name, and we can't allow this to taint our profession because so many of us, we can't let these bad apples ruin the whole bunch. So many of us do the work. So many of us, do the research, make sure that what we have is what we have before, escalating. And it's so many fingers to point at and blame to be had. But I think first and foremost, you as a coder have a responsibility and duty in making sure that you put in the time to do your research and follow your coding guidance and follow the conventions in your manuals. Period. Point blank. That's your job. That's your primary job.
Absolutely.
Every day, all day. Yep. Well, this was good. I'm glad, because I felt it in, like I said, I felt it in your spirit when you were like, wait a minute, let's talk about this. I said, okay, let's talk about it. So thank you all again for joining the Saturday morning tea. Let me ask, was the tea spilled today? Yes, I will answer. Yes, Mr. Jesse, that tea was spilled. Some extra hot tea was spilled. Everybody's saying yes. So if this information was valuable for you, thank you for the birthday wishes. If this information was valuable for you, help us share this message with others by liking the video, sharing the video, especially for those in the coding arena who you want to make sure that they understand what their role is first and foremost. And subscribing to the channel. I told y'all I gotta go. I need your help. I need your help to help me get to that goal of 10,000 subscribers with a stretch goal of 20,000. Yeah, I'm putting it out there into the universe. So subscribe to the Professional Reimbursement Network YouTube channel. You can also check out the Coding Nurse channel on YouTube and subscribe to him as well. Last but certainly not least, to my Clubhouse folks, click on the greenhouse to join in the fun in our club, and you will get notified of our live broadcast, which is on Saturday mornings at 9 a.m. Eastern Standard Time. Remember, we will not have a broadcast next week, but we will definitely see you in 2 weeks. So, Mr. Jesse, did you have any closing thoughts?
No, as always, I thank you for creating the space, and I enjoy being part of the discussion.
We love having you. We're glad you're part of the discussion as well. Yes. Where would we be without you? So we're glad that you are here, always dropping knowledge, spilling tea, hot tea, all of the things, and giving us something to think about. You know, as we navigate our profession, as we navigate our roles within the organizations, and hopefully folks are taking action and providing additional education to not only themselves, but also to their peers. So thank you. Again, this has been a great session today. Thank you for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Happy Easter. I forgot to mention that. Happy Easter. Bye-bye. Okay.